All right. Well, good afternoon, folks. At least if you're on the East Coast, good afternoon. This is Brandon Garrett, CEO of the National Minority Quality Forum. I am here like I am every Friday to sort of educate and talk about a specific topic in healthcare. The topic that we're going to discuss today is the importance of National Minority Health Month. And I know we have, I am going to join this conversation today as I work at NMQF, and the boss, the guy that I don't I'm pretty sure you know that I'm not Dr. Gary Pucker, and so I'm going to join today by two communications experts, actually, who probably can do a much better job of getting this info to you. And the first one is Adjoa Kyerematen, correct? Yeah, yeah. She is a big Tar Heel fan, and she is is the communications lead at the National Minority Quality Forum. In addition, we have Kamar Jones. She is joining us, and me and Kamar were both former CBC staffers. Her with Congressman Richmond, me with Congressman Cleaver. She is a Mizzou alum, and if you know anything about Mizzou, it's also a very good school. It has a very good school of journalism as well. Brandon Garrett, Aggie, so Aggie all the way. So three big schools represented. I think between us, we have about a few million people represented just with our undergrads alone. But I'll go ahead and turn it over to Adjoa, who can set the stage for the programming. Before I do so, I just want to give a couple of announcements. One, if you have questions or concerns or anything, excuse me, have a concern or anything, I just want to leave the discussion, please place that in the chat box, and we'll try to look at that as they come. And then if you have Q&A and you want a question answered by somebody on the panel, put it in the Q&A chat, and we'll get to that. And so without further ado, Adjoa.
All right. Well, first of all, I'm a Tar Heel alum as well. So not just a fan, I'm an alum, proud Tar Heel, born and bred. That's what they say. Well, I'm just so glad you all are joining us for this conversation about National Minority Health Month, which is in April, right? And so it is a federally recognized observance, which is so important because it's a galvanizing effort for all of us to sort of focus on how are we all uniquely and then collaboratively advancing the concerns around health inequities, particularly as it impacts minoritized populations. And this has, been an observance for over 20 years. And we're going to talk today a little bit about the history of National Minority Health Month. And I'm so glad that Brandon Garrett, who knows a lot about the history of National Minority Health Month, will help fill in the gaps of what you might not have known regarding how this all started. Because, we need to understand how something started before we know how we're moving forward, right? And then Dr. Kamar Jones, it will also then weigh in on exactly how it's continued to be moved forward, how the effort has been taken up by HHS, the Health and Human Services Department, as well as other opportunities that we might see for as far as priorities and focus areas as we try to address health inequities and health in minoritized populations. I am going to share with you as our VP of Public Affairs and Comms at NMQF, just quickly what NMQF is doing this year in regards to National Minority Health Month. And I hope to see everyone at our April Leadership Summit on Health Disparities, April 29th through the 30th at the Watergate Hotel. If you haven't already registered, please go to our website at www.nmqf.org to register, because that's how we continue the discussions and conversations and see where there might be collaboration. So first I'm going to show my screen. So yes, I just wanted to at least share with you all a little bit about the history, and then of course Brandon is going to expound a lot more on it. But if you didn't know, NMQF was originally called the National Minority Health Month Foundation. And in April of 2001, the foundation at the time launched a campaign to institute the National Minority Health Month. This was really in response to planning that was undergoing at the time at the U.S. Department of Health and Human Services to put together goals and objectives for the Healthy People 2010. And as you know, we're now currently in the Healthy People 2020 effort. So at the time, it was a really an audacious effort to try to input, the concerns around minoritized populations into this larger plan to address health promotion and disease prevention at HHS. And so around the time that the Healthy People 2020 came around, NMQF came about. So meaning we graduated from National Minority Health Foundation to National Minority Quality Forum that you know today. Of course, when we talk about the history of National Minority Health Month, Booker T. Washington efforts to kickstart National Negro Health Week is often referenced and mentioned as the first real national effort to try to call some attention to health disparities for minoritized populations, specifically Black American populations back in 1915. So it's important to recognize that effort as well, because certainly a lot of what we learned then helped to form what we understand National Minority Health Month today. And so the objective is clear, what is our capacity to eliminate disproportionate burden of premature death and illness for these special populations. And I would say that what else is important to understand and recognize in the evolution of this conversation is that the minoritized populations are not necessarily always minority populations. Is that we do make up majority populations in significant geographic areas that the emerging market, if you will, of minoritized populations plays a significant role in the overall discussion of healthcare, from everything from how do we close gaps, how do we innovate, and how do we consider health in the development of therapies, is that these minoritized populations play an extremely important role. And then lastly, I just wanted to share with you all and invite you all that NMQF, our focus this year for National Minority Health Month is empowering communities through data. As you know, NMQF has a long tradition and history of seeking data-driven, evidence-based solutions to address disparities and to reduce patient risk, and to reduce what we consider preventable burden on specific populations. This year, there's been a ton of conversation about clinical diversity in trials. And so, again, as I mentioned about, recognizing the important role minoritized populations are, that includes in the development of breakthrough modern therapies, and that has to start at the clinical trial level. So there needs to be more diversity and inclusivity in clinical trials. And so we are calling just special attention on that. How can we try to implement real solutions and activities? As this has been even just recently recognized by the FDA. Okay, what does the implementation of that look like? So through our effort called My Clinical, we are hoping to invite industry practices across the country to participate in our efforts to diversify clinical trials across the country. And we're looking at doing that through oncology, through our cancer stage shifting initiative as well. So if you visit our website, as well as our National Minority Health Month.org website, you'll find more information about how you can participate in My Clinical, as well as ARC, which seeks to engage community clinicians, recruiting community-oriented clinicians, minority-serving clinicians in clinical trial opportunities. Secondly, another big conversation, and I believe this was mentioned by our HHS Secretary Becerra only a month ago, was about this conversation regarding equitable access to data and the consideration of race, sexual orientation, in data collection and the standardization of that effort. It's so important to have comprehensive data in order to actually quantify the impact of inequities. And we are part of the data equity. NMQF is part of the Data Equity Coalition, which has a series of activities over the course of this year to advance policy opportunities to address inequitable access to data and inadequate data collection that addresses race. And then lastly, there's been some conversation about the concern of racial bias and artificial intelligence data collection. And this is something that NMQF is seriously paying attention to, and is starting to put together a cohort of experts in this space to really analyze the role of AI, predictive analytics, and the potential of that, as well as how do we monitor and neutralize as best as we can the racial bias that exists in the development of AI. So I've said a lot, and they're happy now to pass the baton over to our panelists today. But again, this is an invitation for you all to participate in NMQF's activities regarding National Minority Health Month. And now I'm really looking forward to the discussion about National Minority Health Month across the country, from history to today. So first, Kamara, would you like to share a bit about your perspective about National Minority Health Month and its role and its importance?
Sure, and thank you to the National Minority Equality Forum for having me. I'm sure y'all read the flyer, but I'm former Principal Deputy Assistant Secretary for Public Affairs at HHS, recently transitioned. But really, I have to thank NMQF because we really picked up the baton here years ago after a lot of great advocacy by NMQF. So they pushed hard with some other folks to get National Minority Health Month to become a reality. And then HHS understandably was tapped to carry it out. And I don't know if you all know this, but this year's theme is Be the Source for Better Health, Improving Health Outcomes Through Our Cultures, Communities, and Connections. When Brandon reached out and said, would you be on this panel, the first thing I thought of was the kidney article. That's the first thing that came to mind. You're probably wondering what that is. I had just read an article in WAPO, but it's in several places, where an algorithm used to assess the health of kidneys was really biased toward assessing African Americans' kidneys as healthier than they were. So that meant African Americans were were less likely to be referred to a kidney specialist if they need one, and less likely to be referred for kidney transplants. And so as we think about data, I have to echo my former boss, who I adore, and I'll get to why throughout the panel, but who said, look, love telehealth and the ways that technology can really help us see things we wouldn't otherwise see across races and genders and sexualities. But we also have to make sure bias isn't baked in. And so that kidney algorithm is an example of bias being baked into the detriment of Black communities, which is really the root at why we had a National Negro Health Improvement Week, and now now it's become National Minority Health Month. I think when I think about this topic, it's not just about disproportionality around chronic illness. A lot of times we live there. probably the second place we go is sort of breakthroughs that will help sort of certain communities. For example, FDA approved some key breakthroughs around sickle cell earlier this year. We also, I think, have to talk about the workforce, because so much of what we experience as, you know, minoritized communities, which I love that term, is because we have people in the industry who are not culturally competent. You know, the only, you know, folks of color they've experienced are folks who look different than them that they've experienced are coming into their doctor's office. And so I think that also should definitely be a focus of ours, because how we're treated in the doctor's office really determines outcomes. And I'll stop there and let my other panelists weigh in.
Well, I'll just go ahead and provide a bit more of the history behind it to start. If you all guys all know, Dr. Puckrin, he has his he's not a physician by training. He's actually has his PhD in history, and so he kind of came after he was a professor for some time. He kind of began to study both how people you know, lived, died, when and where they were when they died, and what caused the death. And I know it sounds pretty morbid, but he used that information and intel. Using that information and intel, he figured or noticed the disparities in death. Like, obviously, we talk about this a lot now, but in the mid 90s, I don't know if it was discussed as much as that if you lived on the north side of Chicago, you're likely to live 30 more years, live 30 years longer than if you lived on the south side of Chicago, for example. So he studied this and studied these health disparities. And obviously, if you know Chicago, and I'm just using that example because that's the area I'm familiar with, that north side is kind of affluent and white, and then south side is a little less affluent and black. And so you notice these sort of not only monetary but health disparities. And notice that folks were dying, they're dying dying earlier and at higher rates, and things like, you know, of heart disease and hypertension or cancer, and you know, just environmental factors. All these things play a part in the reason someone didn't live as long. Sickle cell disease, for example, like if you just knew the history of sickle cell and why you only live to live in your mid-30s, and just sort of the history of like going all the way back to slavery, why that it occurs. And so what he did is he studied this, and he's like, what way can we shine a light on this, right? What way can we get more people to understand this? And kind of came up with the idea with over time, you know, knowing history and knowing about National Negro Health Week, to make up a National Minority Health Month. And so came up with the idea of National Minority Health Month, made it, I'm not certain, I'll be honest, I don't know why it took place in April, but that's why, maybe that's what Congress allocated, or that's what the time it was passed, who knows, but that designated April as a National Minority Health Month. And through that, that also led to the NMQF just being able to collect the data. So if you know anything about NMQF, we've been collecting patient records for years, at least since 2000, and we have over 5 billion patient records, and we analyze and assess this data and go take a bit of a deeper dive for communities about why the community isn't as healthy as it could or should be. And so that's a little bit more color to the history of National Minority Health Month. And then another thing about NMQF, if you like, for example, if you kind of come to our summits from anywhere from our meetings from 2002 to present, there's always sort of been a data angle, and this year is no different. The theme is, you know, we have the data, now what? We've been collecting this data for over 20 years, and a lot of times in the beginning, we'd have this discussion around data, like just letting folks know the same sort of gruesome stats that I mentioned earlier. But, you know, we've been doing this for a while. We have a little more cachet. We have a little more funds. We have a little more people paying attention to us. We have, you know, deputy assistant, a former senior person at HHS on this call with us. We have communications experts on this call with us. What can we do? And so that now what angle is what we're really going to focus on at the summit. And a lot of the topics that we talked about, like AI and clinical trials, is something that's going to be discussed. Cancer care, we've been doing a lot with the Biden administration, even when he was vice president, and the initial cancer moonshot, and then to now being sort of one of the leads on the data space in cancer. So Minority Health Month is super important, and especially as we've trended into an area called precision medicine. Now we really look at the background of folks to see how we best can help them live a healthier, more sustained life. It's just even more important.
So I want to kind of continue the conversation a little bit more about the role of data. And Kamara, you mentioned the kidney test, but not everybody might be up on the news and understand what exactly happened there. So essentially, it just came out that a widely used test that uses a series of algorithms had been overestimating how well African American people's kidneys were functioning, which was essentially making African Americans look healthier than they really were, and keeping them out of or being it became a barrier for African American patients to gain access to kidney transplant treatment approvals, which, if for those of you who are in the kidney space, understand that that's already very difficult. It's very difficult to get authorized to get a kidney transplant. It's a long waiting list. So if you have a test that is delaying or misrepresenting the condition of a patient and treating African American patients differently, um, then that is only exasperating the disparity issue with kidney treatment. So this is just an example that people are really paying attention to, because it happens to be a new discovery that's happening in the midst of this conversation of um, AI and the kind of human biases that informs AI, as well as just, again, this long, old conversation when it comes to health equity about the lack of comprehensive and adequate data collection um, of minoritized populations. So, Kamara, do you want to share a little bit more about your thoughts in regards to this, and what the kidney example says about we where we might need to focus on when it comes to addressing health inequities, and um, perhaps what we should all be discussing during National Minority Health Month?
Yeah, of course. I mean, you basically had an algorithm that was sending African Americans to the, back of the bus when it came to kidney treatment. And so algorithms don't come out of the sky. People create them and people have biases. So we have to take an affirmative action when we're creating these algorithms that help doctors do their job, more efficiently, more effectively. We have to make sure we take, affirmative action to ensure that the algorithm isn't leaning one way or the other, meant to the detriment of certain groups. And making sure, anything, assessing existing algorithms to make sure that or to determine whether we need to unbake any biases that exist. So there's a lot of excitement, and there should be, about sort of, how technology can move things forward, how technology can and data can make things more efficient and effective. But we also have to, keep our put our thinking caps on when it comes to equity, and make sure that that doesn't get lost.
Yes, and I also just shared an article from Penn Medicine that talks about the conundrums of healthcare algorithms and race, because it's not all bad, but it's also not all great. So we talk about the kidney test underdiagnosing, misdiagnosing um, African American patients, but then there's the example of, prostate cancer screening algorithm that was found to overtest African American men, and perhaps what some, especially maybe the payer community might say, was leading to overutilization of prostate cancer confirmatory tests for African American men. So it's a delicate balance as we try to figure this out. But I think what the point is maybe is that, who should be at the center of this conversation? Who should be driving these considerations? How could we maybe perhaps better come together, or ensure that those impacted are at the center of these conversations? I'd like to pose that question to both Kamara, Brandon. How do we ensure that the right people are at the table having these conversations?
Brandon, do you want to jump in? If not, I can jump
You
in.
go ahead and I'll follow. Sorry.
Okay. I think stories really help illustrate things for me. I was in a meeting with the secretary, and we were about to roll out a big study. And he said, what is the equity plan to ensure we recruit people who were disproportionately impacted by the situation into the study? And the response he got back was a lukewarm response, a response that was essentially like, of course, we want to make sure the study is diverse, but there was no real plan to ensure it. And so when you talk about algorithms, a lot of those algorithms are based on research and studies. And if we're not in at the ground level, if a major longitudinal study has been done and there were only 3 Black people involved, then what's going to come out is not going to be helpful to maybe the whole population, but definitely to African Americans. The secretary talks about garbage in, garbage out. And so we have to be mindful of that. And it really starts at that sort of research study level, a level that we're often excluded from. Also, I want to talk about sort of who you can tell a leader by who the leader has around them. I've been at HHS twice. I was at HHS under the Obama administration, and obviously I was just at HHS under the Biden administration. There's a lot more diversity at senior levels under Secretary Becerra. Now, let me say one thing. I don't think it should be up to minoritized populations to always identify and raise these equity issues, but it definitely helps. It definitely helps. Another story, we were working to address monkeypox, and monkeypox was disproportionately affecting men who have sex with men, and those populations are in key sort of urban centers, one of which being Atlanta, right where the CDC is. And so one of the things I had said was, we have a plan for Pride, but what is our plan for Black Pride events? At which point a well-meaning colleague reached out to me and said, when you say Black Pride, do you mean Black Power or Black LGBTQ folks? And I said, Black LGBTQ folks. And so you can imagine sort of, and if I wasn't at the table, or maybe others weren't at the table, that we would have had possibly had a outreach plan for monkeypox that would have excluded those pride events of color. So it's so important, because if these communities are not top of mind, I mean, we know they're going to get left out. And let me stop there.
Yeah. And one thing I always say, and both Adjoa knows this better about me, and I think Kamara knows this as well, that I always think about, like, how is this monetized? Because I think that's how that's gonna play out the best, and you'll have more people participate. And so if you look at it, one thing is just the changing population, right? Like, whereas Hispanics and Hispanics used to be 12% of the population, we're now folks of Hispanic descent we're upwards of 20 and 30. And we have our largest states in the US, like California and Texas, that are mostly, if not there yet, on the way to be minority majority population. So that is the population that you have to sort of talk to, because they're the growing numbers. Additionally, we haven't looked at, or better word, properly resourced diseases and whatnot that impact minority populations. I mentioned sickle cell disease earlier. It's mostly obviously a Black followed by brown disease, and it's mostly in the Southeast, and then in cities like New York City, Chicago, anywhere where the Great Migration happened, either from the Caribbean or from the Southeast. And we have not given enough resources to that. Whereas like, I don't want to say sort of the comparable disease, but a disease that with the same amount of people that affects more of the majority or former majority population would get 5 times as many resources, whether that be studies, whether that be just nonprofit organizations that support it, et cetera, et cetera. So that also just gives a lack in what is done. So you have more people suffering from these diseases because there hasn't been the same amount of resources dedicated to it. There aren't the number of treatments. There aren't even the number of treatment centers. They're not even the number of doctors that work in this space. You can look at, maternal mortality issues. You can look at obesity. At one time you could look at HIV and whatnot, but what HIV event of all the others tell me is that if you actually put the resources behind stuff, you can have dramatic change in how something is looked at. You can have dramatic change in the actual resources that go to awards, and you can actually cure a disease, more or less cure a disease within someone's lifetime. I look at the movies and whatnot about AIDS in 1980s and 1990s, and then working with folks like Gilead or other like organizations with like Carl Maloney or AmFAR or whatnot, we see, while it's still a big issue, we see that there has been dramatic change in therapies that are available because there's been a better focus on it and it's resources that have been properly allocated towards it.
Wow, man, you said a lot there to unpack. One is you talked about, what uh, is the inequity problems that we see in healthcare being properly resourced. And you talk about what gains they've been made in this space also, and where there could be some improvement. So as we look at National Minority Health Month and we look at the broader issue, I do think it's important to note that you know, as far as perhaps some gains or intentions towards allocating more resources to addressing health inequities, is that we have the Office of Minority Health now at HHS, right? And that got established in I believe, 86. And having a dedicated office with a budget at the federal level to continuously look at health inequities all year long should be helpful. Um, I also shared in the webinar chat for our audience, and of course, please, we're welcoming folks to raise their hands and ask questions, and also provide some thoughts about perhaps where there should be priority areas for National Minority Health Month. Brandon talked about several other issues: obesity, maternal health. Um, so please weigh in here on your additional thoughts. But I did put in there the updated Health Equity Action Plan from HHS that was updated, I believe, earlier this year. That does try to point to or help industry, if you will, focus on where there is need, where there is where additional resources are needed. And this came around the time as well that to Kamaro's point about the importance of leadership. Secretary Becerra had a big roundtable discussion with Black leaders across the country for Black History Month to try to get a sense of where there could be priority areas, particularly for the Black American community, as part of the discussion for Black History Month. So, but the Health Equity Action Plan talked about maternal health, um, prioritizing behavioral health, talked about what we've just discussed also in this panel about the need to increase clinical research and child diversity amongst minoritized populations. Do you think that there are other areas of importance that have not been addressed appropriately and should be perhaps receive special attention during National Minority Health Month?
I'm just going to be, I guess, be a parrot here, but I would also say I would always have to say data, because just the appropriate data is important. Making sure we, like Kamara said, you can do a study of 100 and you only have three, Black or minority participants, and you're going to get, trash in, trash out, or bad data in, bad data out. And so I think data is one of them that just like, I think that data would sort of set the stage and the standard for it. I mean, I know one member of Congress, and what he does is for his staff, he sort of every year or every session, he tries to match the demographics of his district to have so he has a good analysis of the folks that he represents. And so I think that maybe not as direct as that, but something to that effect would definitely sort of better impact results and the just not only the results, but the things we choose to look at and give it to highlight.
So I would second that. The other thing I would say, which I've been itching to talk about, is workforce. And so the secretary actually has a workforce initiative. It's not mentioned in that plan, but it is something he's focused on. And it's involved talking to, the professional associations within the healthcare industry. I should mention that for Match Day, he went to Howard University. So making sure we show up at medical schools of color. He went to the National Medical Association's conference. He was the first secretary to do so. But workforce is so important because when you walk into that doctor's office, if the physician or nurse or whoever can't see you, does not see you as fully human or sort of with a full sort of scope of humanity, then that's going to affect your outcomes. I remember being at in the hospital room of a close family member, and I could just tell the doctor was uncomfortable dealing with the older doctor was uncomfortable. Older white doctor was uncomfortable dealing with our family. The younger doctors who reported up to the older doctor, they were more comfortable. They're younger. They're from a different generation. They're used to being in diverse spaces, but they weren't controlling, my family members' care. And so it's so important that we push folks in all communities, in all minoritized communities to, get that, nursing degree, get that medical degree, get that psychiatry or psychology degree, because it really affects outcomes. I've heard some horrible stories. One I read about, and then I'll tell you two that I heard secondhand. So WAPO again did a story on maternal health, and the Black woman recalls the person looking at her sonogram. The baby was wiggling around in her belly, and the person looking at her sonogram calling the baby a little hoodlum. Number one. Number two so that's story number one. Story number two is we have, and this again goes back to who you have around you as staff. We had a Black Health Summit, and this was probably the first in the history of the department, definitely the first in recent memory. It was started by a former Black colleague of mine, Marvin Figueroa, who's now Chief of Staff for Senator LaFonza Butler. But it was at our second Black Health Summit, which was a few months ago. A Black woman told me a story. A Black woman in healthcare told me a story of a Black couple who, I think it was a stillbirth or somehow had lost their child. The husband started getting really emotional, as you would if your newborn baby did not survive, and the hospital called the police. And she said, oh, that happens often. It happens often that when folks of color start to emote because of a death of a loved one or poor service, that the police are called. So criminalization happening at the bedside of a loved one who may be sick. Last thing I'll tell you is another maternal health example. It comes from a friend, and she said, a black woman friend of mine, I journaled every appointment, every doctor's appointment I had when I was pregnant. I journaled it. Now you probably are thinking, oh, she journaled it because she wanted the memories to look back on. She was journaling, she told me, because if something happened, she wanted to be able to pinpoint, have a record of maybe when stuff started to go south. People shouldn't have to think like that when they're pregnant, right? To document every interaction in case something bad happens. So it's really real, I think, workforce in terms of making sure, the workforce looks like us, because it's really life or death.
Yeah, speaking of that, just like, again, acknowledgement of the evolution of this conversation, that should be recognized for National Minority Health Month. It's the fact that implicit bias, racism has been more widely recognized now in recent years. A lot of folks point to the George Floyd incident and the conversation it raised, that as being sort of like a catalyst to increase acknowledgement in industry, as well as by institutional organizations. The American Medical Association, for example, really recognizing the role of racism in the healthcare system, and implicit bias. I would say, as a plug for NMQF, shameless plug, we we really have been talking about that for a long time, and that is why for our Center for Sustainable Healthcare and Quality (SHC) has a dedicated program to address implicit bias in practices by helping with quality improvement training of clinicians. Because in the absence of a diverse workforce for some practices, at the very least, there should be proper training to acknowledge implicit bias and to try to mitigate against that, to ensure that all patients have appropriate care and have the right to optimal health care. I want to apologize that I've been all this time during this webinar, I've been referencing all the articles, and I didn't realize I wasn't sharing it with everybody. So all the articles are now in the chat. um, and so for you all to reference, as for the various points in this discussion, um, for sure. So, but to then also go to a point Brandon was making about what kind of investment, the money conversation, when it comes to addressing health inequities. I did include an article about the economic burden of racial, ethnic, and health inequities in the US. Um, Kamara had also mentioned that this is not uh inequities in our system is not just for the impacted communities to be addressing, it's for everyone to address, right? And that kind of goes to this conversation about the burden, the economic burden that is placed in our health system when inequities continue to persist. Not only is it a civil rights issue, a human rights issue, what we're saying is that it doesn't logically even make sense to have inequities exist in our health system. So, so Brandon and Kamara, what do we think that the role industry could play more in trying to address this concern of the economic burden of inequities? How can industry help to absolve that issue, you think?
Yeah. I think one of the things is partially just first addressing and recognizing it that the industry hasn't always done that, and to not only there but to everyone's detriment, right? The scourge of I guess the scourge of racism and sexism is everybody's burden to bear, and so they have to know that industry has to know that they've been a part of that. I think what industry can do is just start to recognize it. And I don't want to sort of highlight just everybody, but I do want to. It's just on top of mind. Johnson and Johnson has been doing a lot of work on um, health equity, but programming around National Minority Health Fund. And I just want to acknowledge them and other organizations that have been doing so, just recognizing the work that needs to be done. Additionally, looking at sort of therapies that can that honestly help more minority people, whether it's the work that customer company X like Vertex, for example, is doing in that kidney space or sickle cell disease. I mean, we are at the point now because of its resource that sickle cell disease, that we do have a a 95% cure. The only issue is that it's very expensive, but we're at the point that we've done the research to get that close to. the cure, and now we just have to make it more. We have to make it more affordable for folks. But it's I think it's on the way, and that's and it's just realizing everybody has a part to play in it. The government has a part to play in making it better. The industry has a part to play. Individuals like us have a part to play because we have to a lot of us we're lucky in that we learn this stuff. We are familiar with it. But I can have a conversation with my cousin or my brother even or someone, and they have no idea of what's happening in this space or why it is important to have these discussions or why industry even is needs to support this more.
So I love that you mentioned the player in industry, and you mentioned some pricing models. You mentioned pricing because that's the first place I was going to go is, hey, when you roll out these new therapies and drugs, I get capitalism, but you can do carve outs for certain communities. I mean, we saw that with the vaccine when it went commercial. The secretary said, I want an option for the uninsured. And so we worked with those big drug companies to ensure those who were uninsured could still get the vaccine for free. So you don't have to make 100% profit with every sort of group. You can stagger it. Other thing I was going to say to continue my workforce theme is making sure your C-suite, especially, but throughout your company, looks like America. Also, that you're not bringing a device or a drug or some other product to FDA that you haven't seen sort of looked at through an equitable lens. So often people will sing the praises of something that's widely used for this or that, but when it's used for a certain community, it has an adverse effect that nobody knew about because they didn't look at it. So, maybe it's a new product or maybe it's an existing product, hair relaxers that's been on the market that is disproportionately used by a certain community, and you need to take a second look to make sure it's supports the health and well-being. So those are a few things. Oh, I want to say one more thing back to workforce. These industries can help get folks to college and through these programs with scholarships or give them internships and fellowships so they can launch their career. Healthcare is a overwhelmingly white space, and so any sort of nudge there would be great.
And I'm just gonna piggyback off of that, and I have to say this, and just full disclosure, I work on the board of trustees of Xavier University of Louisiana, and they are very known for their impact of getting more minorities, Black specifically, in the workforce, whether that be physicians, clinicians in general, pharmacists. And I think part of it is like because I grew up around Xavier, I always had. While I didn't become a clinician, I did still work in the healthcare space, and I was always exposed to it because I had Xavier University around me, and I had a grandpa that went to Meharry. Like I've always seen sort of Black professionals in medicine, whether that be just around luckily in my family, and then probably even more luckily like in the community that I worked with. So I always saw that, and if you can see it, you can believe that you can become it as well. And so I think these types of feeder programs and research programs and things that expose kids to all of this. I did every summer program at Xavier from 8th grade on, and I have a lot of friends that are physicians from that very program. Right. And so I know that sort of exposure, and whether that to be to the research space and they work in pharmaceuticals, making the pharmacology, making the actual therapies, or bioengineering, or they're pharmacists or they're physicians or nurses, or dentists, right? That really has a positive impact.
I love that you said that. I'm a mini medical school graduate. So Mizzou has mini medical school, and that was really the first time I had seen sort of young Black folks say I could be a doctor. We had one Black doctor that I was aware of, one African-American doctor that I was aware of in my hometown. And so ultimately I chose to go another way. I think it was because of interest, but also I'll be honest, I had good math and science grades, but I was scared of that next level of math, that next level of science. I want to say one last thing specifically about PWIs where they can lean in. I know your question, Adjoa, was industry, but I know for a fact that at a lot of PWIs, folks know that the medical school and the nursing school are where minoritized students are don't matriculate because of the culture within those schools, right? And so take affirmative action there to change the culture. So Black women and brown women and Black and brown men, et cetera, who go through these schools can actually make it out with their self-esteem intact, with the grades they need to match at a admirable sort of hospital or whatever. I know personally that at Mizzou, you'd hear stories, oh, we have 6 Black women in nursing school hoping to get 2 out. It shouldn't be that way when we have sort of the usual suspects running amok to prevent certain folks from matriculating.
That's a really great point. Well, I would like to wrap it up if there are no questions from our audience with just some helpful information about how folks can get more involved with National Minority Health Month. So I'm going to show my screen again here. Oops. Yes. So again, here are the objectives for National Minority Health Month as directed by HHS, which is generally to build awareness and to try to encourage some action through interventions in community and education. Upcoming events that they have, HHS is sponsoring for National Minority Health Month include a fireside chat at Morehouse on April 22nd, and also a minority health walk on April 11th at NIH's campus here locally in the DMV area. You can go visit their website, hhs.gov, National Minority Health Month, / National Minority Health Month, to learn more about more activities, as well as perhaps engage with your own events as well. And then what NMQF is inviting you to do. So, we believe strongly in working in community with community. And so we're providing a pretty helpful toolkit that you can access to help build capacity. Some of the issues is capacity. A lot of health equity programming is still driven by communities themselves. And then, unfortunately, a lot of the minority-led community-based organizations don't have enough of their own resources to have sustainability over time. So we're sharing a toolkit of how to engage community members in health events to promote health education, promote community interventions within their own communities to tackle health issues. We all Kamara mentioned earlier about stories, the importance of stories to align with the data, right? Sometimes it's the stories that help the data come alive for people to understand just how harmful inequities can be. And so NMQS Lift Every Voice program launched a story collection of patients impacted by disparities in the health system throughout the month of April. And we invite you to participate also by visiting nationalminorityhealthmonth.org. And then lastly, because of the conversation around data, just a reminder that NMQF with our partnership with Blue Cross Blue Shield Association, again, industry trying to play a role, as well as 17 other organizations, that through the Data Equity Coalition, we're really trying to improve how we address inequities and actually see improved health outcomes. It's not enough to just educate and talk about it and build awareness. Action needs to result in seeing improved health outcomes. So please look into our Data Equity Coalition at dataequitycoalition.com. And so with that, I think we're right at the 1 o'clock mark almost. Brandon, any sort of ending words? that you
No,
want to?
well, yes, I guess I just want to say first one being thank you for everybody participating and letting sort of us sort of run amok on this conversation. I think just piggyback on some very salient points. I think Adjoa mentioned in her conclusion, just make sure that if you are industry or an individual, whoever, partner with someone that does work in this space on a sort of data database, whether that's your local FQHC, if you're a corporation or a business, or even a big government. Work with the local FQHC, hear the problems that are happening on the ground, and learn from those communities and those leaders that are handling it. And then one thing that we talked about the summits in the past, I was one of the ones that we did back in 2020 was racism makes me sick. And so make certain that is a very true statement. Dr. Cameron Webb actually did a presentation on it. He actually went through why racism makes me sick. So just knowing those things and knowing how to properly address them, and I stay involved, stay focused, and stay learning.
I'll just echo that and say, one, yes, we have an Office of Minority Health at HHS, and yes, we're tapped with leading on National Minority Health Month, but definitely under this secretary, it's a year-round focus. And if there's something that that should be a focus, there's definitely ears to hear and eyes to see at the department. So reach out and and be heard.
All right. Thank you guys so much for joining us. The recording of this webinar, as usual, will be posted on NMQF's YouTube channel within the next day or so. So if you wanted to sort of share these thoughts with others who weren't able to make this webinar today, you certainly will be able to do so. Thank you, Kamara, Brandon. Have a great
Thanks,
day.
Angela. Thanks, Ashley.
See ya.